Greetings of the season. I'm Dr. Vijay Varad. I'm practicing allergist, pulmonologist, and clinical immunologist in Pune since last 27 years. So last few topics we talked about how the novel approach to the management of allergic rhinitis, as well as how the allergic march as a practitioners we should how our role is there. Now today we will talk about the what advances have been in allergy. Suppose a patient comes to the pediatrician, how it should be managed. The symptomize is okay, but long term we should say. Even not only the pediatrician, even the dermatologist, a family physician, the ENT surgeon, or chest physician, the patients come to their own perspective, the symptoms wise. But how allergy as a systemic disorder, we should remember that. It may start with the food allergy or skin problem. Later on, from the nose, it can go to the airways like childhood asthma or rhinoconjunctivitis, and then it can go to the skin also. So it can change from one part to another part. So it is amongst the global diseases. It can affect the whole body of the patient. Later on, the patient can have a significant. So even like traditionally, the Bengal gram or milk massage is given to the lot of children. Why it should not be given now in India? The people will talk to us. See, we are using since ages. So why still you advise not to use it? Because the genetics had changed. This allergy is also one of the genetic disease. Hereditary part is definitely there. If the parents are suffering, 66% the child may have a similar allergy. Both the parents are suffering, more than 85% chances are there. Grandparents or first degree relatives and all. Now the cutaneous sensitivity starts from the dendritic cells into the skin. So that's why these massages, the food particles, they will sensitize more to the patients. So we should ask the parents not to use these things. And as I mentioned, the cutaneous sensitivity, the dendritic cell will definitely trigger these T cell responses, then interleukin, and allergen specific IgE, the mast cells which get triggered. The mast cell degranulation lead to the different inflammatory mediators. And then depending on the localized systems or systemic symptoms like anaphylaxis and all, the patient will have a severe reactions to the food allergies or drug allergy. So do we advise any test for the even atopic dermatitis, urticaria, rhinitis, asthma? Yeah, allergic rhinitis, allergic rhinosinusitis, allergic conjunctivitis, allergic asthma definitely is around 65 to 80% of the patients. The allergy tests are helpful. But even the food allergy patients like GRD like symptoms, repeated colics also, the specific food allergy test can be useful. In even selected patients of atopic dermatitis, suppose there is a strong family history or the child in is having a very early stage response and there is a definitely trigger by the food intake or some exposure to the some dust or bed after going to the bed or early morning late night, then the dust mite sensitivity can be there. There it has been found that 30% of the children may have a food trigger. Around 60 to 70% also environmental factors can trigger these patients. So pathogenesis wise atopic dermatitis, there are distinct microbial signatures discriminating between atopic dermatitis with or without food allergy have been identified. So again, atopic patch test also has been used as a to assess the food allergies. Besides the nasal steroids, what about the nasal saline irrigation advised to the children with allergy? So even for the adults also it is there. So nasal irrigation is very important in all, even from newborn baby to the adults or even geriatric age group also. Because whatever the allergens are here, they can be washed properly. Nasal hygiene, if it is maintained properly, the sensitization, the inflammation, the sinuses blocking, and eustachian tube blocks and all also can be prevented. The nasal provocation test with the grass pollen and house dust mites was found to be positive in 25% of non-allergic rhinitis petition, strongly recommended to consider and diagnose local allergic reaction also. And saline nasal irrigation with buffered hypotonic or isotonic solutions, depending on the age group, definitely will help to the patient. Again, the advances are there. 95% of the children with rhinitis have ocular allergy, which is missed, underdiagnosed, overestimated, and that's why repeated rubbing and all causing a keratoconus in a early stage, requiring thousands of lesser treatments to the adolescents. Then overuse eye steroids are causing early cataract and glaucoma. So as I mentioned about that, the comorbidity, the central part is the rhinitis. 95% can have conjunctivitis, then 40% may lead to the asthma. Amongst the asthmatics, children 90% have allergic rhinitis. Adults 65 to 80% have allergies, food allergies, eosinophilic esophagitis, eczema. So that is there. So this 2018 also World Allergy Organization has mentioned about that. And while managing these patients, localized eye steroids are also important, but most important, it is a localized effect of a systemic disease. So the nasal steroids also, and oral montelukast, belastin, oral montelukast, fexofenadine, leocetrizine, molecule also should be given during the season. 40% of the children and 20% of adults with asthma have symptoms suggestive of allergic conjunctivitis. Establish links between the allergic rhinoconjunctivitis and other atopic conditions, including the asthma, eczema, food allergy, eosinophilic esophagitis. And ocular allergy has been increasing in frequency, often undertreated health problem. So it's because of non-life-threatening causes, people don't take a care of that. So it is now considered as a one away, one disease. Even two-thirds of the asthmatics have symptoms of allergic rhinoconjunctivitis. Suppose this allergic rhinoconjunctivitis, as I said, 2023 also and 2017 European Academy, and mention about the allergic rhinoconjunctivitis. If it is not treated properly, so you see this case, this child 7 years was referred to us. Last 2 years he had a cold cough and all, but now significant even Seals ulcer were formed, and he was suggested the intraocular steroids. The parents they asked the cornea specialist what are the side effects of the intraocular steroids, and when they said the early cataract and glaucoma can be there, and it can affect the eyes, secondary infections, keratitis, then they rushed to us, and we started analyzing the patient. After proper selected allergen testing and all, the omalizumab is a biologics, 150 milligrams subcutaneously. The child had a very immediate relief, no intraocular steroids after the fifth dose also. And immunotherapy, we are continuing with simple precautions. And you can see his clearance of the Seals ulcer also, and his eyes also so clear, and he is enjoying the life. The serum IgE was 110. So about 30 also, these allergy patients, and the skin prick test showed them dust mite, perineblomia, and parthenium sensitivity. So while going to the school, we asked the patient to use the mask as well as nasal douching, nasal saline irrigation with the montelukast and fexofenadine combination, leocetrizine combination was given to him regularly for a few months. So these integrated approach as a precautions also, I will say it is advances in India because most of the patients have not been given a guidance about the environmental control. And some patients are given such a guidance that stop everything. So it's very difficult. So rather than that, if you do the proper simple allergy test, which are painless, bloodless, hardly skin prick test is 100 rupees per allergen. Immediately the report is available. We can identify that and we can guide them what allergy the child is having. Are the nasal steroids are helpful in the rhinoconjunctivitis? Definitely, because there is a nasoocular reflex, nasolacrimal duct inflammation going on, and then the localized ocular area also has a sensitivity. So localized polynosis. So definitely the nose and eye share the same arterial blood supply coming from the internal and external carotid arteries. And so uh, the venous flow also connecting the eye and the nose. So the nasal steroids and the montelukast, belastin, fexofenadine, or leocetrizine, depending on the season, should be given for. You can see this picture how the nasolacrimal duct and this nasoocular reflex is connected. Here you can see these nerve endings which are connecting this reflex. So how common is the keratoconus? Definitely, there is significant lot of cases have increased nowadays. Previously, then steroid-induced glaucoma and blindness in VKC patient. There are so many studies done. So these are the actual advances, and these are underdiagnosed and not treated properly. Otherwise, the asthma and other cases they are managed with the biologics also, even proper triple drug, double drug inhaler therapies. But the this rhinoconjunctivitis is missed by most of the people, and then it leads to the nasal polyps, obstructive sleep apnea, and complications. Well, snoring, many of the people have underlying allergic inflammation, and that is missed by many of the practitioners. So these ocular allergies should be taken very seriously, and rather than rhinitis, it should be the rhinoconjunctivitis. Again, how to improve the quality of the food allergy children's? What steps we should improve in our practices? There is a misconceptions about the food allergy. Hardly only 5 to 8% of the children have a food allergy. Adults also hardly 0.5 to 2%. And there is a cross reactivity many of the times. So some of tropomyosin into the prawns, which is a cross reactive to the derpy one in the dust mites. Then latex sensitivity children will have a cross reactivity with the fruits. So that's why after eating the fruits, the child has a problem. Then birch pollen has a cross reactivity with the apple, multi one. So that we can identify properly and we can treat. So wherever actual food allergy is there, after consuming the food, within 2 to 3 hours, the child has a hypersensitivity. Other things, suppose he consumes a large amount, it is an intolerance. So there is no need of any test also for intolerance. Even there are now oral food challenge tests, component is all diagnosis as advanced. Even epitopes or proteins different, we can analyze into the food. Why prescribe the anti-allergies? What should be the approach, for example, rhinitis urticaria patients? That's very important. The peripheral receptor blocking, H1 receptor blocking drugs, and we should not cause the blood-brain barrier, non-sedative, and we should have a effect of analgesics and antipyretics also. They should not irritate the GIT, so diarrhea or acidity should be less. Prolonged intake, tachyphylaxis should not be developed. The bind with the blood protein, risk of the toxic effect during the dehydration, cachexia, secretory function of the kidney should not be affected. Muscarinic-like effect, anticholinergic action, they decrease the secretion of the mucous glands of the respiratory system. So reverse bronchoconstriction happens. So that also should not be there. So such type of drugs should be. So second generation like levocetirizine, loratadine, fexofenadine, bilastine, avastin, these are non-competitive blockade of H1 and antihistaminic receptor. They do not penetrate through the blood-brain barrier. They do not irritate the GIT because our tachyphylaxis does not develop, do not bind with the blood proteins and anticholinergic action is absent. So such type of molecule should be there. Even nowadays, the fexofenadine, desloratadine, levocetirizine are said a third generation one. Bilastine has been added nowadays, which can be increased in a higher dose also. Even fexofenadine can be given up to 4 times dose also. Only cetirizine should be prevented because it causes a lot of sedation. Levocetirizine also higher dose to increase the double or triple or 4 times dose is not possible practically. It can have a sedation. Role of probiotics in allergy. It's a very good nowadays. Probiotics have a very good role: gut lung axis, gut brain axis, gut skin axis, gut eye axis, and so the probiotics have a very good future. Proven probiotics for preventing the atopic dermatitis has been proven. So even during the pregnancy, they can be given. Respiratory probiotics also, the studies are happening. And how you can see that the inflammatory responses and it induces the mucosal IgA production of tolerogenic immune responses as well as allergen specific B and T cell responses. Probiotic administration alerts the gut microenvironment by promoting a change in the local microflora and in cytokine secretion and can potentially modulate the toll-like receptors and the proteoglycan recognition proteins of enterocytes, leading to the activation of dendritic cells and Th1 response. So the Th1 response will prevent the secondary infections, and the Th2 inflammation triggers the secondary infections. So you can see how the probiotics against the pathogens also they have action and they reduce the allergen specific interleukins also. So inflammatory response is also reduced. So both ways they are having a very good response. Any steroid sparing treatments available in India and how should be the approach? So stabilizers of the mast cells membranes. So anti-leukotriene drugs like montelukast and all. Zopurlimolast is available outside, not in India. And then monoclonal antibodies. They are very good. Even sodium bromelain glycolate or nadochromyl of sodium has been. Even recently, just now, I came in across there are some ultraviolet rays nowadays in allergic rhinitis patient. They are given and they can reduce the pharmacotherapy also. So such type of advances happening and long-term wise, then specific immunotherapy, where we actually produce the antibodies against these specific IgEs and leading to the IgG1, IgG4, or IgA immunity. And long-term wise, it is the only disease-modifying therapy which can prevent the progression of the disease as well as it halts the liver sensitivities and further complications. So if you see that surgical strike like molecular targets of the biological therapies, there are so many biologicals are studied nowadays Omalizumab is against the anti-Ig, Dupilumab is against IL-4, IL-13, Mepolizumab is against IL-4, IL-5, then Benralizumab is against IL-5 receptors, and these Tezepelumab as the anti-TSLP. Recently, we completed a clinical trial against the IL-33 in a COPD patients with the higher eosinophil count. So these biologics have a very good recovery. They are covered under the insurance also nowadays, and definitely it improves the quality of life so much. Like one of the neurosurgeon, we had a very poor quality of life. We could not play, we could not go to the trekking and all. After giving a proper biologicals, after 4 to 5 months, he started going to the Himalaya and he's enjoying the cricket and all. One of the radiologists also from Pune, who had a very poor quality of life. He, after coming home and all, very irritated, does not mix up with the family, or he always used to just sit on in front of the TV and all because he used to be exhausted. We started a treatment and he's enjoying the life. These targeted therapies, as a uh, since many years, omalizumab is used, and how it has a different actions on all these different sites, and it reduces the inflammation and constriction of the airways. And since 1998 also, the World Health Organization white paper has been published. Rest of the things like decongestants, the antihistamines, the montelukast-like molecules, mast cell stabilizers, oral and parenteral steroids are overused in India. Monoclonal antibodies have been already started using in India. Then they control the inflammation. The response to the allergy management, asthma management is good, but long-term wise, the progression is not stopped. So allergen avoidance and the immunotherapy are the only treatments that modifies the course of the disease, preventing the newer development of the sensitivities and altering the natural history of the disease and disease progression. In day-to-day practice, practical tips to avoid the allergens, air purifiers, vacuum cleaners, are they available? So if you see the asthma or any of the allergen control is very important. Suppose the pesticides can be used to control the pests and all. Then removal of the mold and from the some damp walls under the bathroom or the basins, and some kitchens and all. Liquid ammonia 5% also sprays can be used. Bedding covers and all, the carpets or the deep beds. There are nowadays pest controls for these dust mites also. Then cat and dogs should be avoided. They should not be on the bed or sofas. They should be kept outside. And outdoor allergen avoidance, the use of the masks and all, closing the windows, HEPA filter air or plasma clustering technology, air purifiers, nullify these effects. Can we do the allergy test? Actually, worldwide, since more than 100 years, the tests are done, even in asthma, rhinosinusitis, obstructive sleep apnea, skin inflammations, GIT symptoms, and all. In India, the awareness is lacking. Actually, the specific immunoglobulin IG levels in skin prick test is the still gold standard. Nowadays, even component diagnosis, the immunocap technology is useful. Other molecules like immunoblot technology, Euroimmune technology, ELISA methods, and the outdated ones are used. They are not useful. So if you want to go for the blood allergy test, selective important one, but the cost is high. Now component dissolved diagnosis is very good for the food allergens. Even we can pick it up the proper epitopes or different proteins into that. And rest of the environmental allergens, still gold standard is the skin prick test. So that's why the Indian College of Allergy Asthma Immunology 2017 also has given an importance for the specific IgE testing and then the specific allergen avoidance rather than unnecessarily telling the patients about stop everything and all. It's not needed. And again, the cross reactivity of the foods should be clinically correlated, and we should guide the patient that sensitivity of the food does not mean that it is allergy. And where we can prescribe the allergy immunotherapy. If you see all the guidelines by all British Society, European Academy, American Academy, WHO, even USA's different bodies, Galen, and Indian College of Allergy Asthma Immunology, they have mentioned that allergen immunotherapy has a characteristic not shared by the drugs in the capacity to modify the natural history of the asthma due to its immunological mechanism of actions. This also works after the treatment withdrawal. So around 25 to 38 years, the effects can be lasting for a longer period. Very few patients may develop a newer sensitivities. Then to prevent the relapse or remission, sometimes they may require a longer period of desensitization. But most of the patients within 3 to 4 years, they have a very good response. Reason for low is that the insufficient information of allergen immunotherapy to the colleagues also, and availability of extracts with less than good quality. But now, last 5, 6 years, A lot of things have changed, and even the standardized extracts are available nowadays. And so the patient will have very good results. Where the allergen immunotherapy or allergy testing? So IG-mediated diseases like allergic rhinitis, conjunctivitis, sinusitis, asthma, even otitis also repeatedly, stinging insect hypersensitivity and atopic dermatitis in patients with aeroallergen dust mite or some Parthenium-like sensitivities, or insects droppings or dried feather or pigeon feather sensitivities. Sensitization is relevant for the symptoms. Symptoms are of sufficient severity and duration and insufficiently controlled by the avoidance and pharmacotherapy. Availability of a standardized high quality allergen extracts for the specific allergen intended to be used for the immunotherapy. And what we can expect about this advanced therapy: improved efficacy over the symptomatic treatment, early onset of efficacy, sustained and increasing efficacy, long-term benefits, prevention of sensitization, prevention of chronic respiratory diseases, reduction of the need of steroids in asthmatics or ocular allergies, cost effectiveness over the symptomatic treatment. But in the food allergy also, the repeat or allergen, technically we have to ask, is it within 2 to 3 hours or a late phase intolerance? If it is intolerance, there is no need to go for the test. Skin specific or atopic patch test, specific IG component dissolved diagnosis. Then, depending on that, oral food challenge is the best one. Double control or double arm, we can say. The patient also should not know which food has been given. Then, but there is some risk in India. Still, it is not done so routinely. So, specificity and sensitization pattern also should be analyzed. If patients on oral or sublingual immunotherapy develop gastrointestinal symptoms, they should be evaluated by endoscopy for eosinophilic gastrointestinal disorders also. In urticaria, how useful omalizumab before the immunosuppressants? Definitely, there are studies done in the urticaria, and these biologics are very good before the cyclosporine or methotrexate and all. So, rather than that, the omalizumab has been more than around 60% of the patient has shown. Even the angioedema, different type of, besides the hereditary angioedema, otherwise, where idiopathic or chronic spontaneous urticaria, the omalizumab has a very good. And any biomarkers test in asthma towards the newer therapies, these interleukins and all management will definitely change, and these biomarkers can also be analyzed. Once that awareness will be there, and the people will definitely want to invest in these markers. So in our hospital also, we did this biomarkers test, and these interleukins and Th2 inflammation we analyze, and definitely it has been found. Again, in the drug allergies, routine blood tests are recommended, but not scientifically and theoretically, because those will have false positive reactions, because very few drugs they really cause a drug allergy. Rest of the other times, their excipients, preservatives, coloring agents, and additives, they trigger the things. Only like cephalosporins, penicillin, or macrolide group, as well as metronidazole group of NSAIDs, they really cause a drug allergy. The rest of the other molecules may not be. So the triad of this pathomechanism, diagnostic process, and management, you can see depending on the pharmacological interaction with immune receptors. Actually, pseudoallergic reactions also should be differentiated, and very few patients really require. And we should be prepared for the anaphylaxis in the OPD basis, because a lot of cases of anaphylaxis are increased after the vaccines or after the NSAIDs, after the IV drips, even the multivitamins also triggering the anaphylaxis. So identify the patients which have a high risk factors, identify the hidden signs of allergy. As in the previous lectures, we told about the turbinate hypertrophy, dark circles, Denny Morgan folds, derriere line, like this rubbing and eyes and all, cervical lymphadenopathy in the children, or the significant family history. Then the epinephrine, adrenaline should be kept for the intramuscular administration, 0.5 ml in the adults, and 10 kg, 0.1 ml, 20 kg, 0.2 ml, 30 kg, 0.3 ml in the prefilled syringes. And these are the common causes of anaphylaxis. Typically 10 types of food, then bee stings and penicillin and other drugs and all. Anaphylactic reactions also because of the dyes and all. And these are the symptoms. So acute, it's like a shock-like status, like a heart attack. And so patient's identification should be done very early, and then we should be prepared. Underuse of this adrenaline and all causes some more complications, because once the patient goes into the multiple organ involvement, then it becomes very difficult to reverse. So always suspect Keep everything ready. 2.5 ml syringes always in our OPD. And whenever suspected, give it immediately intramuscular. Nothing happens, which is very helpful to prevent that. Over recent years, research has been provided immense progress in the understanding pathomechanisms of allergic diseases as unrivaled new therapeutic approaches. With the development of the novel therapies, we face a new era of disease management, number of unmet needs. For example, understanding the role of genetics, its interaction with the environment, monitoring disease severity, response to treatment, and preventing the allergic disease. But definitely, a lot of improvement has happened. 70 to 80% of the patient have a very good quality of life, reduce the symptoms, reduction of the oral or parental steroids is achieved, and we can prevent a lot of complications in these patients. Thank you. Thanks a lot.